Thank you so much, Henny, for inviting me to give this lecture. Henny is one of my most favorite professional colleagues. We've met at many conferences. We've discussed many issues together, and I think Stellenbosch are very privileged to have him as the head of obstetrics and gynecology. And thank you, Henny, for all that you bring to the citizenship of obs and gynae in South Africa. So what I'm going to do tonight is just a little bit off the wall. Instead of my usual talk about P53 and retinoblastoma and HPV infection and cervical cancer, I decided that that little organ, which is 4 centimeters long, could take a back seat. And we can start with our reflective practices. And I must just say that before I started writing this talk, our dean committed suicide, as you know. He was a man that I loved deeply and whom we all love deeply. And his loss has really broken our hearts. And funny enough, this talk refers a lot to the circumstances under which doctors, healthcare workers, nurses get broken by the system. So this, as I have turned 60, is my new focus. It's not just about science. So this is just a little bit ad hoc. This is Hygeia, who is the daughter of Asclepius, which is in the sign for the medical profession. He was the god of medicine. And Epione, who was the goddess of healing. And this is Hygeia, who was the goddess of sanitation. And she's one of the statues at the top of Groote Schuur Hospital. And I look at her every day, and every day I think, thank you for inspiring me to reach greater heights in terms of being a doctor. So in my first year at the UCT Medical School, which was in 1976, the country was in turmoil. Steve Biko was detained and murdered with the collusion of our profession. And it was a shocking experience. And for a young 17, 18-year-old, it was quite unbelievable, who still believed in Florence Nightingale. It was particularly realizing the extent of the collusion of our profession in the execution of his death that my heart felt broken. South Africa has a history, is one of turbulence and great pain, characterized by colonialization, brutality, the denial of humanity of those considered other, gross abuse of power, lust for control of land and privilege, and this is both pre- and post-apartheid. In the hospitals in 1976, when I was a first-year student, black and white wards were segregated. Black students were not allowed to examine white patients, and the black wards overflowed while the white wards were virtually empty. There was a deep sense of outrage and injustice amongst many of us. The unfairness of our privilege over others was haunting. We were known as the medical school, some sort of God-given temple. We were not the faculty of health sciences. Only doctors had credibility. The context in which we operated was an institutionalized racist society. There was a huge gap between rich and poor, which persists today. There was overt discrimination and exploitation of black people of all classes. Black women were the most oppressed, and this persists today. Healthcare was geared towards tertiary institutions like Groote Schuur, which we lauded, disease-orientated, and they were Eurocentric. And South African doctors were highly regarded and actively recruited for northern countries. Primary healthcare and services for the poor were neglected. More than 50% of graduating doctors left the country for the UK, the USA, Australia, and Europe. The skewed and unequal health services left the majority of South Africans in poor health, and it is now well understood that a major obstacle to the development of society as of a whole is an unhealthy population. The shooting and random shooting of young black people who transgressed the rules of the law was a common event. And this is my beautiful hospital where I've been my entire life. I always call myself an institutionalized child. On this side of the building was the white side. And actually up here, over there is where my office is. And that was a white ward in those days. And we've subsequently built the new hospital. So medical school had this reputation. It was notoriously difficult to gain entry. Those who came from top schools were prioritized. The selection criteria were opaque and geared towards privileged students. There was a great aura of respect for professors and HODs. Everybody jumped up within seconds. And they had absolute power and very little accountability to the structures around them. Many enforced petty rules: if you hadn't shaved, get off the ward round, and regulations to maintain the power differential. Intimidation, humiliation, contempt, top to bottom, were common and applauded. It was long, and punishing working hours were considered a rite of passage to become a member of the tribe. Our hierarchy was rigid. It was a boys' club. Women were definitely considered inferior species, so we had to endure many insults. Vulnerability as a quality was disdained, as it still is. Empathy, compassion, person-centeredness was really unknown in the vocabulary of our work. Egos were allowed to run ragged without checks and balances. The pursuit of a balanced life was really for sissies, or maybe morphies, or new age types, but not normal people. Errors were either ignored or used to undermine, especially juniors, without any compassion for the trauma suffered by the individual. The message to patients was, do as you are told. So it was a very patronizing patriarchy, which I'm afraid still exists. So what were the consequences of this institutional culture? Poor management of staff, inadequate technical or only apprentice-style training and teaching, do as I do, with minimal flexibility, lack of understanding of the need for humane care of staff, students, and patients. The fact that we were so disease-orientated resulted in lack of attention to holistic wellness, prevention, and raising awareness among healthcare workers and disempowered patients. Poor morale amongst healthcare workers. There was a high degree of fear and defensiveness, and there was a lack of engagement between staff and management, lack of effective clinical governance. There was a lack of understanding that as doctors we are, or were, perilously close to failing someone, even if it was our intention to do no harm. Failing to share and understand our collective pain as healthcare workers as we confront enormous human suffering, much of which we cannot fix or is out of our control, is one of the important consequences. So we have this huge burden of disease. We have this very low resource allocation to the public sector. And one of our challenges is, how do we close the gap? So how do we deal with the gap between the burden of disease and resource allocation? Because we know that that gap is a major barrier to good clinical care and to socioeconomic development. So how do we address this? Okay, let's throw more money at the problem. We could actually turn to fair and more equitable management of staff. We could emphasize the role of bringing humanity to the forefront of medical practice. We could critically evaluate how we measure one another, because our main emphasis is on research and publications, research funding, international collaboration and recognition. And I don't know about your ad hominem process, but these are the key factors. Whereas we talk about social responsiveness and we talk about teaching and learning and we talk about leadership and administration, but actually what we talk about is high impact factor journals, the Lancet, New England Journal of Medicine. That's what makes you worthwhile. We have little reward for bread and butter, rock face, clinical service, or dedicated teaching and training. Which leads to the concept of engaged scholarship, where we intercolate research with clinical service, social responsiveness, teaching and training, much of which is just a thought. So how do we manage our lives? How do we stay motivated in an increasingly complex, competitive, and ever-changing environment? How do we as healthcare workers challenge the hierarchical paradigm, the power relations, and overwhelm experienced by so many in the public sector, but also in the corporate world and society in general? What tools are there to close the gap, not mind the gap, between demands, needs, and resources? How do we ensure that the medical paradigm is inclusive of patients' needs and priorities, and the understanding of the role and impact of family, community, employment, physical environment, social injustice, etc.? So what is burnout? Well, the word is thrown around all over the place. Apparently first described in 1974, though I've read first described in 1942, by this person called Freudenberger. And he wrote a book called Burnout, The High Cost of High Achievement. And he defined burnout as the extinction of motivation or incentive, especially where one's devotion to a cause or a relationship fails to produce the desired results. It usually occurs in the context of chronic work stress and is characterized by exhaustion, cynicism, disconnect, disengagement, and feelings of professional inability, among many others. So what are the risk factors for burnout? Well, let's just look at the life of a registrar in specialist training, and I'm sure there's some of you here. You work long hours, there's lack of adequate rest, recreation, lightness of being. There's no protected time for research or reflection or recharging. There are multiple demands for your clinical skills and competence at all hours of the day, 24/7, constant supervision of junior staff, and often very inadequate supervision by senior staff. And in some provinces other than our own, senior staff aren't to be seen after 10 o'clock in the morning, but they take home a full head of clinical unit salary. We're now required to study for and to pass specialist examinations. It's now compulsory to perform a research study for specialist registration. So there's this issue of family, work, and life imbalance. We are expected to multitask, which the Buddhists will tell you is toxic. And we have a heavy load of responsibility without any real power. So no wonder half our staff are screaming. And this is from Edvard Munch in 1983. So what options are there? Well, there's this beautiful picture which appealed to me because of her serenity. Rati, the goddess of love. And she's so contained, and she's so in one space, instead of us scattering around like chickens without a head. So stress is considered the global health epidemic of the 21st century, and this has been stated by the WHO. Resilience has been described as the ability to rebound from adversity or a process of adapting to adversity. So resilience is about how we recharge, not what we endure. And the three major characteristics of resilient people are a staunch acceptance of reality, a deep belief that life is meaningful, and an uncanny ability to improvise in the face of adversity. And there are many activities that increase resilience. And these include discussion, talking, fora like this, where we actually bring the subject out of the closet. Inclusive decision-making, worker-friendly policies that enable team decision-making through mentoring, clinical support, and supervision. Mindfulness is the new buzzword, which means paying focused attention in the present moment to all that you are encountering. The practice of mindfulness is now known in randomized controlled trials, which the professor of psychiatry was trying to point out to me don't exist, but they do. The practice of mindfulness is now known to predict the accuracy of judgment and insight related to problem solving. And it enhances cognitive, and that's your interpretative, flexibility. Other aspects that build resilience are to compartmentalize our cognitive load. Look at what happens with social media and email. And if you just sit there, stuck to that computer, you can actually have your eyes turned square. We need to take detachment breaks. Apparently, we can concentrate for 90 to 120 minutes. You should stop every 90 to 100 minutes and just do something different. There is bend forward or stretch or take 3 deep breaths, but that is part of building resilience. And when I saw this, actually I was at an airport and I saw Time magazine talking about mindfulness. I was just blown away. This was in 2016, and it was a whole magazine devoted to the science of finding focus in a stressed, multitasking culture. And what are some of the antidotes to this burnout phenomenon? Well, one of them is to develop mental agility. Respond rather than to react to a difficult situation or person. And I don't know how many difficult people I've encountered in the last 25 years who evoke some sort of violent reaction within one. And one keeps having to learn to say, actually, there's another way of dealing with this. We need to decenter stress, neither deny it nor suppress it. But we need to pause to observe the experience from a neutral standpoint and then try to solve the problem. Pivoting attention from the narrative network in our brains, which is yada, 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 can't stand you, da, 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 to our more observational parts of our brains. This person is stressed. This person is behaving in this way because this person is not coping. And we need to develop the core resilience skill of what's known as response flexibility, the ability to pause, to step back, reflect, shift perspectives, create options, and choose wisely. And then there's cultivating compassion, self-compassion and compassion for others. Compassion has been shown in randomized controlled trials, some in which the Dalai Lama has been involved in, where it has been shown to increase positive emotions, create positive work relationships, and increase cooperation and collaboration. And this is just one of these things. I see it's very common to find these on Google Images about all the different aspects of mindfulness. Now, I just want to turn briefly to leadership, because leadership has come under the scrutiny of many organizations internationally. So you can think of leadership as, well, I'm the boss, it's individual agency, and you do what I say. So it's traditionally assumed to be something done by the hopefully talented few, exercised over the many. Or should it be the result of system design and a collective social process emerging through the interactions of multiple actors, such as a group activity that works through and within relationships, and I want to emphasize that word relationships, rather than individual action, known as distributive leadership. And in modern times, the concept of shared leadership, collective leadership, collaborative leadership, co-leadership, emergent leadership have all gained traction. And if you go into the literature, there's masses on it. And then there's complex adaptive leadership, where the organization of many connecting parts enables you to respond to changing circumstances. There's the paradox, where you have two opposing states coexist in seeming harmony. So it's not about either or thinking, but both and thinking. Leaders need to be, actually, good leaders need to be able to follow well and enable others to take the lead, rather than just provide the lead themselves, expecting others to follow. But then we have this phenomenon of trumpitis, which flies in the face of all these images. Now, there's a hyena picture I took in Botswana. That's one type of leader. Gets the bait, takes it to the people. He's the boss. There's a hippo who looks so benign, rather ugly, I would say. But don't get in this person's way. Because what happens when you challenge this animal's power? And what happens when you have ineffective leadership? And in the light of the Ebola crisis, which has absolutely fascinated me, this commission emphasized that human and health security must be people-centered. It's people, it's not borders, it's not international borders, it's not money or even economics, it's not military defense of national borders, but it's people who matter. Multidimensional security threats are interactive. Infectious epidemics, poverty and inequality, and violent humanitarian crises result in weak governance and poor leadership. The Ebola crisis vividly demonstrated that the political and economic effect of a massive infectious outbreak was catastrophic, particularly in the context of poverty and conflict. We found through this crisis that protecting people's lives through disease control requires decisive, inclusive, responsive leadership, which was lacking. Look at the WHO, who were pathetic in the beginning, as well as strong healthcare systems, largely lacking in poor countries due to the inequity of distribution of resources, the impact of globalization, and the top-down approach. So health system resilience is the capacity of healthcare workers, institutions, and populations to prepare for and effectively respond when crises occur. And what we've learned is that borders do not protect the world. So you could be sitting in northern Germany, but the crisis in Ebola is in Africa. You're not going to be protected unless there's a world response to that event. This leopard I followed for 2 days and showed the most amazing resilience against the world by being alert and by being conscious and watching every movement that happened around her. It has been said by my favorite poet, David White, that the antidote to exhaustion is not rest, but it's wholeheartedness. And somebody said, well, what does that mean? And it means engagement with the life within us and around us. And this is just another beautiful picture in Botswana. But John Kabat-Zinn, who was the inventor of mindfulness, said, practice sharing the fullness of your being, of your best self, your enthusiasm, your vitality, your spirit, your trust, your openness, but above all, your presence. Share it with yourself, with your family, and with the world. And thank you very much for your attention.
Denny, I would just like to thank you. Prof. Denny has inspired me since I was a baby medical officer, as a gynae oncologist, as an avid researcher, and an advocate for women's health. I'd like to thank you for crossing the Boerewors curtain, or Boerewors line, to give us the Jane de Villiers lecture. And I hope that you will have inspired us to greater heights and brought the subject out of the closet that we're all so scared to speak about. And you've provided us a lot of encouragement to practice more people-centered. And when I say people-centered, I mean the staff and the patients, people-centered medicine. So thank you very much. There's a token of our appreciation.
Thank you very much. Thank you so much.